please join me in welcoming Dr. Schmidt, who would be explaining to us what systems medicine is and how healthcare would be changed.
Sabah al-Khair, Shukran Jazilan Lida Awatakum, Al-Karima Limutamar Dubaiya Al-Mumtaze. I think you have all known of the major socio-economical revolutions that we have experienced in the past 100 of years. For instance, the introduction of the steam engine, railways, electricity, petrochemicals, and automobiles. And these were usually revolutions, which means major concepts, major companies disappeared, and major concepts, completely new companies appeared. For instance, when the steam engine came up, sailing boat makers said, oh, we need to make bigger, faster sailing boats. No, it was the end of sailing boats, maybe recreational sailing boats, but not commercial ones anymore. And also, the development of an electric light bulb was not an incremental improvement of a candle. It was something completely new. And I think you will agree with me that we have experienced such a similar revolution in the IT area. But we are at the end of this revolutionary process. We have our Googles, we have our Facebooks, and analysts agree that the major socio-economical revolution that we are now facing is a completely new definition of health, how we achieve it, and how we pay for it. So, in the first part of my talk, I will talk about the bad things, sort of the decline. This shows the 10 most grossing drugs on the market. And in green are shown those patients that will benefit from the therapy. Those red ones are those which, according to current guidelines, will also receive those drugs. They will not benefit from the drug. If they have bad luck, they will have the unwanted side effects of the drugs. And currently, we have no way of differentiating between the green and the red patient. So let's look how drug discovery, the discovery of new drugs, is moving on. You may have heard that in the 80s we had an exponential increase in costs. Now the average cost to develop a drug is $5.8 billion to bring it successfully to the market. And despite this increase in costs, you will appreciate that the outcome, sort of the new medical entities that have actually been entered the market, is more or less constant. So if costs increase exponentially, and the outcome remains the same, the efficacy has a problem. Now, let's have a look at that. This is the efficacy of drug discovery since 1950s. And you will appreciate that we have a linear decline. Actually, this is a logarithmic scale. So we have a constant decline since the 50s. The thalidomide scandal, which totally changed drug registration regulations and so forth, didn't cause a major decline, or the introduction of biologicals, which are a little bit marketed as the big next revolution in medicine, also didn't improve it very much. So if something is on such a linear decline, maybe there is a conceptual problem in how we define diseases and how we develop drugs. And all analysts actually agree that by the end of the 20s, it will be the end of the pharmaceutical industry. There will still be a couple of drugs developed. And even in 2028, there may be a company developing or bringing a new drug to the market. But there will be an equal amount of companies that will fail because their concept is wrong. And apart from the problems in research, and you have mentioned the research on mice that we're mainly focusing on, is our concept of disease. This is the International Classification of Diseases 10th revision that we're currently using in medicine. And the main feature is that we systemize diseases according to the body organ. So we have basically for every organ a specialist. We have a cardiologist who works in a cardiology department. We have a nephrologist who works in the nephrology department, a neurologist and a psychiatrist who focus on the brain, a gastroenterologist, and so forth. As if we could divide the human body in little sections and just deal with this organ and understand everything about this disease by focusing on that organ. Or even worse, we name a disease after a doctor. After Dr. Alzheimer or Dr. Parkinson, they observed something in patients, some symptoms, and they named the disease after themselves. And my favorite one is to name a disease after a symptom. And here my favorite disease is hypertension, elevated blood pressure. I assume there will be some attendees here who take antihypertensive drugs in the moment. If you get the diagnosis from a doctor that you have hypertension, in most cases, it's essential hypertension. 95% of the patients with hypertension get the diagnosis, essential hypertension, which means you have elevated blood pressure, but we don't know why. So you get drugs that dilate blood vessels. And big surprise, your blood pressure drops. But the cause for all of this is unknown, and therefore the cause cannot be treated. It's a bit like your car is going crazily fast because your accelerator pedal got stuck. But you don't want to look there, you don't want to know. So you hit the brake. So your symptom that your car is going too fast disappears. Your car will definitely slow down. But the reason for all of this, you have not even addressed. Plus, I don't think it's a very healthy situation for your car if you do this. And that's what we're doing with our body. Now, let me come to the positive side of things. There is developing a perception in medicine that maybe things are not that simple. So, for instance, there is the gut-brain axis. We heard about depression. The microbiome is apparently a major determinant of the development of depression. We actually have the same neurotransmitters in the brain and in the GI tract. Maybe that's not a coincidence. There is the brain-heart axis. Heart failure and depression, or Alzheimer and coronary artery disease have the same risk factors. Alzheimer and coronary artery disease have the same risk factors. Maybe they have the same underlying mechanism. The heart GI axis, for instance, the microbiome of the GI tract is probably the most important determinant of your basal blood pressure. Not when you're stressed or when you're running or when you're exercising, but your basal blood pressure. We have a Max Planck Institute in Germany for the heart-lung axis and a collaborative research center for cardio-renal problems. So medical people are slowly realizing maybe we have to approach medicine in a little more systematic manner. And a key paper, one of the best papers I think in medicine that has been published in the last 20 years, is this one here in the Proceedings of National Academy of Science in the US. This is the network of all human diseases. The bubbles here are the disease definitions. The lines between the bubbles are the genes that are shared by two diseases. So if we take all human diseases and all risk genes that have been identified, we end up with this network. And the colors refer to the normal categories, how we divide up medicine. So basically one color for every organ. Now, if you look at this network, you will see that some of the diseases cluster together. They form little groups. And these are formed because these diseases share common risk genes, which may mean they share common disease mechanisms that we just have not identified yet. And you will see that some of these clusters have only mainly one color. So these are, for instance, all cancers. And maybe it's not surprising that all cancers have probably similar mechanisms. There is probably not so much that can go wrong in a cell to make it a cancer cell. Dysregulation of cell-cell division, of cell-cell contacts, and so forth. And here are clusters of neurological diseases, so some form of epilepsies. Some ion channels are involved there that apparently only appear in neurons. Therefore, it's not surprising that these disease phenotypes are basically brain-specific. But all other clusters, as you will appreciate, are multicolored, which means diseases that we currently put in different categories, treat by different doctors in different clinics, they actually mechanistically belong together. Or organ-based disease definitions like cardiovascular diseases are all over the place. They have symptoms in one organ, but mechanistically they do not belong together. This was the 2D representation. It's actually more impressive when you dive into this network in 3D, and then you actually can better represent the relations between those diseases and see the associated risk genes, which then give you a hint towards the mechanism. So the important thing is it's all nice, but you need to validate it clinically. Otherwise, it's a nice theory. So what we have done is we're working on this cluster of diseases, contains diabetes, stroke, Alzheimer, hypertension, and so forth. And there is one disease like stroke here. Stroke is the #1 cause of disability worldwide, the 3rd cause of death, and there is basically no treatment. We can remove the clogged thrombus in the brain or dissolve it, but that's it. There is no treatment afterwards if you have a stroke. So we said, okay, if stroke is so close here in the network to heart failure and to diabetes, maybe we can repurpose a drug that works in diabetes and a drug that works in heart failure for stroke. If the theory is correct, that a vicinity in this network means similar mechanism and therefore the same disease but different phenotypes. And indeed, we could repurpose 2 drugs which are now in the clinical trial, the first neuroprotective therapy as we predict in stroke. But it's, the important thing of that is this drug repurposing based on common mechanisms of drugs will revolutionize how we actually develop drug. I think we have already all the drugs that we need, almost all of them. And you don't need to go through a 12 to 16 year long, 5.6 billion expensive drug development process starting de novo. You can actually use a registered drugs, find the mechanism, find the disease phenotype with that mechanism, do immediately the clinical trial, so find a new purpose for a registered drug. And it's not only me saying such crazy things, it's a whole movement in medicine in the moment. So, for instance, there's a fantastic paper by Ellinghaus who completely redefined immune diseases. There was also a paper in The Lancet, one of the leading medical journals, which said, let's not use the term asthma anymore. Asthma are at least 4 entirely different diseases mechanistically that just have symptoms in the lung. But asthma is sort of an 18th, 19th century disease definition. Let's not use it anymore. And they also have shown that diseases like colitis ulcerosa, Crohn's disease, rheumatoid arthritis, psoriasis, uveitis, these are all 18th, 19th century disease definitions. There may be a colitis ulcerosa patients, for him, 2NF-alpha antagonists may work, and he also has psoriasis symptoms. This is his disease. He has a TNF-alpha related disease. He has nothing to do with other colitis ulcerosa patients or with other psoriasis patients for whom these drugs don't work. We have to get rid of these disease concepts. And here's another case of retinopathy, so blindness, where they identified it's not one disease, it's actually 3 different disease mechanisms, and once you have identified them, you can cure them. And probably the second best paper in the last 20 years came out last year, a complete redefinition of what we call cancer. So they sequenced millions of cancer patients and identified that cancer can actually be explained by 33 mechanisms, cellular mechanisms. And some of these mechanisms appeared in 25 locations in the body. So to define a cancer by its location, like breast cancer, brain tumor, and so forth, is completely outdated. You have to define the cancer by mechanisms, like all other diseases. So actually, this cluster will split up in 33 clusters, which we then mechanistically understand, at least 33. So coming back to this network, we're actually not interested in these 18th, 19th century disease definitions. That was the start to get organized. We're actually interested in these clusters. But we're actually also not interested in these clusters. We're interested in these signal mechanisms that define these clusters, because they provide then the targets for the drugs that we can use to cure those diseases. Do not treat symptoms. We don't look at symptoms anymore. So how do we organize this? And that's a representation of the interactome in our cell. So everything that goes on in our cells, all protein-protein interactions, all signaling. And then we can basically localize where does this pathway sit that causes these symptoms. That's a complicated at first, but very precise disease definition. So these clusters should then be localized in the desisome, in this interactome, and these precise definitions, basically the 3D localization within the interactome, that will be the mechanistic disease definition of the future. And in practice, a patient will always come with an organ-based symptom to a patient. But the doctor will no longer be the single authority. He will no longer need to rely on the current medical knowledge being in his brain. Of course, he will use databases, artificial intelligence, and the artificial intelligence will then suggest him, we think it could be this pathway. Let's better do a couple of more diagnostic tests, and yes, we have it. And then the function of the doctor will be, in a larger team, of course, he can't do all this alone, to define with the patient, there are several therapeutic options, let's find out which one is for you the best one. And as you have heard before, things are actually slightly more complicated. It's not about all our genes. We have actually 3 times more cells on us and in us, the microbiome. And because they are so diverse, the genes from our microbiome is 99% of all our genes. So we are basically carriers for bacteria. Of us, 1% are our genes. The rest is the microbiome. So to ignore the microbiome and what they sort of synthesize would be naive. So of course we need to take this into account. Now, the fascinating thing is this big data-driven process is actually not so much caught up by pharma, but by the previous IT industry. This is the new business concept of Google. We've mapped the world. Now we do health. So they have founded Alphabet. They have founded a life science company, Verily. They have recruited Thomas Insel from the National Institute of Mental Health, and they bought Seniors Health, and their target is not to collect data, to tackle age-related diseases, which means to treat them. Amazon has bought PillPack. So they want to take off the pharmacy market. Apple has all these apps, Health Kit, Care Kit, Research Kit, and so forth. So they develop an online electronic health record for patients, and Novartis is probably the only pharma company who has got it. The new CEO said, we are no longer a pharma company. We have to be a pharma and a big data company, not a pharma company that uses big data. We are a big data company. And he also said drug companies that only treat diseases or symptoms will fail. Companies have to heal, they have to start healing diseases. The concept of chronic diseases is totally wrong. They are only chronic because we can't treat them. They're not by definition chronic. It's like if you go bring your car to a repair station and he says, oh, we can't repair it. Your car is unfortunately chronically broken. Well, you go, of course, to another garage, right? So that's the positive side of things. And to summarize that, the concept of organ-based diseases will be replaced by systems medicine. It's the end of it. It's also the end of how we do research. Unfortunately, it's the end of pharma. I'm pretty convinced. Maybe 10 years more. It's a huge opportunity for drug repurposing, because I think we have probably almost all drugs that we need, and there will come the point in a couple of years where we will need no new drugs. Why should we eternally need new drugs? Once we have identified the mechanism, once we have drugs that target those mechanisms, that's it. We need to produce drugs, of course, yeah, like our aspirin and so forth, but we don't need to constantly discover new drugs. And we may actually need less drugs. Yesterday you had a fantastic talk about cell therapies. They belong to the concept of advanced therapies, so cell therapies or gene therapy. Once you have identified a gene, fix it, that's it. You never need to eat a drug. And of course, with this, only with this approach, we will be able to differentiate the green from the red patient, plus we will be able to treat all patients and know that they will all benefit from it. So that's precision medicine. Plus, such therapies will in the end become very affordable. We need to invest a little bit, certainly, in this change. But in the end, the efficacy will increase and the costs will decrease. Thank you.